5, 4, 3, 2, 1. We are live now, sir.
Can you see my slide?
Yes, we can see, sir.
This was the workshop for something during the COVID period. And this is the same thing which more or less I am trying to present here. 65-year-old fresh fracture. This is how will you twist it?
65 years. I will get the CT scan done, sir, to just see the medial comminution, not for number of fracture fragments, but medial comminution. Usually, if there is medial comminution and these old age patients, I go for fibula grafting with filosplit, sir. Very rarely with K-wire fixation. Rarely I consider, sir, but if the bone is osteoporotic, now the K-wires they come out usually, sir.
It was conserved 10 days, 4 weeks, 4 weeks. Out of 104 minimally displaced fractures, only 77% resulted in acute or excellent. Although all fractures healed, 90% of the patients had little or no pain. Functional recovery was incomplete. These are all the papers. Also, synthesis versus conservative treatment. This is all these are the articles which we've been talking about. And every time we talk about the proximal humerus, this article always comes into the picture. Conclusion: not any significant difference in pain and the follow-up between those treated with osteosynthesis versus conservative treatment. This is the article. One of these did find that three-part fracture, the conservative treatment seems to be better than osteosynthesis for pain and function. This is again an article in 2014, displaced proximal humerus. Operative versus non-operative treatment, 2 years extension of randomized control trial. Conclusion: this randomized control trial, surgical treatment proved no better results than conservative treatment for patients with displaced proximal humerus fracture in 2 years follow-up. Overall range of motion results in both methods. Randomized trial found relatively few complications, most occurred in surgically treated groups. Infection of obviously in surgically treated groups. Again, proximal humerus. Current concept in classification, treatment, and outcome. Majority of the fractures of the proximal humerus are stable injuries in elderly and can be successfully treated non-operative. Challenge for the future is select those patients who are going to be at increased risk of developing complications of poor function. The result out of a non-operative treatment. Well-designed trials will be required to evaluate whether the outcome in these cases is improved by operation. Another one, proximal humerus fracture early versus delayed motion in non-operative. Evidence describing early versus delayed motion for minimally displaced fractures of proximal humerus suggests that the first 3 to 4 months of follow-up, early motion of the shoulder tended to confer greater overall shoulder function, less pain and greater range of motion than delayed motion. However, in the later follow-up, there was no statistical difference in outcome between early and a delayed motion. When we treat conservatively, we have a delayed physiotherapy time. In one study with 2-year follow-up, 1/3 of the patients in either group reported significant shoulder disability as measured by the cross shoulder disability questionnaire. Conservative, this is operative treatment, complex humeral fracture. On the basis of available comparative data, there is no demonstrable difference in outcome between fracture managed surgically or conservative. There is a need of a large randomized control trial. These articles are a game changer. Every presentation will return material, spoken material. These articles are mentioned. We are confronted with. We always talk about a prover article, which has changed the concept of the people. Every time I advise surgery, I am reminded, why should one operate proximal humerus fracture after such game changer article? The we are surgeons. We do operate. And even feel operation is needed. In the nutshell, if I talk about the way I have understood it, when there is this debate whether to operate or to conserve, then you should be on the side of conservation. Because this fracture, when you conserve, there is no problem. This is not originally displaced. Since it is not originally displaced, this soft tissue envelope is intact, so it can remain intact. And definitely, if at all I operate this, this will be only 2K and definitely not a philosophy. This is what is my obsession. And as I think probably Dr. Sanjay Desai also mentioned about it. And after hearing Dr. Chandok, I have changed over. My philosophy taking has reduced dramatically. 2-part fracture, never. 3-part fracture, almost never. 4-part fracture, yes. That is how at the moment we talk about. So now we go to this fracture. My concept is if the GT fracture in a fracture dislocation of the shoulder, if GT is displaced, after the reduction, GT appears to have appeared come back. But if it is displaced, that means the soft tissue is already been disturbed. If it is displaced, it is not worth controlling this, even if the X-ray appears to be as if it is all right. Now here is the GT, as you can see, it is fully displaced. Post reduction appears as if it is all right. But this is a rotation view, will not be able to confirm this, except to see this guy. The different views you can take. This was the views we took, and this is the GT. It is under the control of the supine, supraspinous and spinous and all. So this is the GT. If it is displaced, stuff is stored. So here you can see that once you have appeared to be on day one as if it is not displaced, then it can displace slowly over 10 days. So even if you conserve, you got to see for 10 days time whether it maintains the structure. But if it is originally displaced, my feeling is that it will probably not remain in position even if the X-ray shows on day one that it will remain in position. It will get displaced and the function is affected. So on day one, to me, fracture dislocation with the GT which is displaced, to me, it is an indication for surgery. What surgery? This is what is the GT is displaced. Best treatment is tension bending. One or two tension bends depending upon what you do. And suture the cup tear which has occurred. So that tension band is going to look after the GT part and the cup suture which you go to do it. The displaced greater tuberosity which methods cannot be of longitude and tear in the cup at the rotatory interval between the supraspinous and suprascapular. Even I have seen my arthroscopist friend doing a very good job of this sort of activity. Can do a good job by static reduction in featuring of the tuberosity. Now these are the attachments of the greater tuberosity. Supraspinatus, posteriorly, infraspinatus, and series minor lower down. This is then posteriorly, this is going to subscapular. We know this very well. This is the view in which you get anteriorly subscapular. Greater tuberosity, 2-part fracture, supra and infraspinatus. And series minor displaced posteriorly and posteriorly. If there are all the muscles are gone, everything is gone there. If it is communicated so many times, supra and infra will come, supra will come, but the infra which is posteriorly situated will be remaining away. So if you, when you are featuring the GT, you got to see that in a comminuted fracture, there are 2-3 pieces. You also will have to find the infraspinatus so that you can get the external rotation. Otherwise, you won't get the external rotation. After now, the screw fixation has become a common thing. But in screw fixation, there are many faults. Like in a comminuted screw fixation, here it will problem there. If something like this happens, this is not a good idea. Screw fixation in a osteoporotic or a comminuted fracture is out. In a young adult with a big chunk, yes, you can do a screw fixation. Otherwise, this is the one which happened, so it was corrected with antibody futures, and this is the one which works very well. So you future it up, tension band, antibody futures, and this is the one which is a treatment of choice for the right. Now, how do you treat this? This is again, you can say two parts. This is my favorite treatment. K-wire, 2 or 3 K-wire. At one stage, I do this percutaneous screw fixation. And after, all these are our percutaneous screw fixation I did. Something. But today, a fraction like this, 2 parts. After Dr. Chandok has talked about this K-wire, it does a beautiful job. And I changed over to this K-wire by large. This is Dr. Chandok. This is the one which works beautifully. I may add up 1 or 2 K-wires if needed. Otherwise, this itself gives you a beautiful stability. So you don't need anything else. Such a fracture today, I never do a at all. So now we come to today's preferred treatment, angular stable. To me, today, 2 plates have probably created quite a lot of more complications than they were before. One is the velocity, other is the distal femur plate. Non-union rate has increased a lot after a distal femur plate, and the range of movement is reduced after the velocity. Velocity plate is indicated only in to me 4 parts. As all of you know, this is where when we put a deltopectoral, there is a debate where the panic vein where we put it. Anybody, the panic vein, once you find it out, you will push it laterally, you will push it medially. This is the anatomy of the whole thing. Anybody want to open about it?
Sometimes I take it laterally and sometimes medially, but mostly I try to take it laterally.
So on a Monday you take it laterally, Tuesday you take it medially. Is that?
Sir, while dissection, if it feels that there are less tributary or medial side, then I take it laterally. Lateral I prefer because then dissection on the medial side becomes easy.
What is recommended is take it laterally. Take it laterally. Because retracting it laterally preserves the drainage from the deltoid. That's the one which is affected. So then we go to the deltopectoral. Now deltopectoral, Dr. Sangeet is going to talk about it. I'll just give you a small review. Muscular patient, how do you improve the exposure if there is a crunch of the place in a deltopectoral? Yes, Arjun, you want to come in? You please understand the question. I'm not going to talk about, because all of you are surgeons, so we don't talk about the standard deltopectoral. But in a muscular patient, when you do a deltopectoral, still you are in a crunch of space. How do you improve the space?
Sometimes you have to release deltoid from the clavicle and acromion.
Deltopectoral is a standard approach. Plate can be to the lateral to the long end of the thigh. You all know this. And as is the answer to that, you may have to detach deltoid from the clavicle for the increased approach. Better it is detached partially from the center of the humerus, down below when it comes to the deltoid tuberosity, and that also can be moved and you will get a better place. While if you take it out from the clavicle, the knee suture is back, and putting back the tension is also an issue. So to me, I detach it partially from the inside of the humerus, and if it helps to take it back to the nearby one.
Sir, may I add something? Tanna sir?
No.
If you detach proximally, is extremely difficult to achieve a strong fixation. So as Dr. Nitin said, you detach distally partially because it will fall back, and don't use a spike distally to retract it. You use only right angle retractor, so you detach only as much as required. And in very obese or muscular patient at times, what we have done is that if we had opened with deltopectoral and we are struggling, then we make a small nick about an inch on the lateral side, a separate incision. So you don't even have to bother about finding out the axillary nerve. You just expose that 2 or 3 centimeter from the acromion, suture your tuberosity, and those sutures are then delivered through a artery forceps or a needle holder in the anterior wound, and you close that window. So a separate lateral window, like a split deltoid, but only proximal part. And you can take the sutures nicely and deliver them in the wound anteriorly. Yeah.
Have you understood what Dr. is trying to say? Then I am talking to you.
I think he's.
Sorry, sir.
Yeah.
What Dr. Negi has mentioned, have you understood?
Sorry, sir.
What Dr. Negi tried to
Sir,
explain?
my,
You are not audible, Nitin.
sir.
Yeah.
Yes.
Yeah.
Yes, sir.
You can take
To
two
bring
incisions.
that greater tuberosity fragment, two incision. One is the deltoid splitting small to bring that posteriorly and superiorly gone greater tuberosity fragment to pull it back to the main incision and deltopectoral. So you need not do the deltoid resection. So that is what probably is saying, sir.
Yeah.
See, now, this sort of a comminuted fracture, medial comminution. This is where Nitin you mentioned about the fibula.
Grafting. Yes, sir.
Medial front fibula is very important for such a badly comminuted fracture. If you try to do the fracture here, this comminution which is there medially, it will give way and you will have a problem. So you put in the fibula and now put in the plate. This is going to be a much better option so that you will be able to get a good stability of this fibula. And ultimately the fracture in the come. What are the problems of deltopectoral? Just now Dr. Negi mentioned. DT is posteriorly and inferiorly displaced is difficult to retrieve. And so you may need additional lateral approach. To remain lateral to the long head of the bicep is a struggle at times in a muscular patient. May have to detach deltoid or a pectoral, and you will have to make abduction in order to remain lateral. In order to plate and screw internal rotation of the humerus needs to be done. Fracture is to be stabilized with K-wires before that and may lose reduction of. I'm only giving you the crux of the matter. Day-to-day things we are not talking about. So the crux of the matter, when we want to remain lateral to the bicep, then you will have to see that the fracture is stable, and then you rotate it. Then only you will be able to do it. In order to plate and screw internal rotation of the humerus is needed, and the fracture has to be stabilized with K-wire before that. Whenever possible, I do it from the lateral deltoid split approach instead of a deltoid. Now I come to the deltoid split. This is a typical deltoid split approach. This is how the deltoid split in a beach chair position. Y and the deltoid split is. This is a partially beach chair position. This is a C-arm above. Measure it 2 inches. Mark 2 inches from the acromion to the circumflex nerve laterally. And as you can see, plate is positioned in the proximal part and the distal part. Put K-wires in the proximal end of the plate and also distal end to see that the plate is properly into the proximal and distal and it's not lying in the air. So you'll have to see that this is in the middle, this is in the middle. So you have to put K-wire and find it. And the original deltoid split was described that here somewhere is the circumflex nerve which we are not seeing. But if you see, this is where the circumflex nerve comes. Deltoid split approach, this is where the nerve is. So if I have changed over from this approach, 2 windows, I changed over because you were never sure of where is the nerve. Nerve is about 2 inches to 3 inches from the abdominal. And that's the reason why nowadays, I open it up and see the nerve like this. Once you have seen the nerve, like radial nerve you see, ulnar nerve you see, now we are comfortable and we can operate upon. Here is the nerve, here is the fracture. So we are quite near that. So unless you are sure of the nerve, this nerve can be damaged, and then you will be able to probably have a problem in this damaged nerve. So,
Tanna sir, in 20% of the people, it can be even less than 5 centimeter. Is mentioned as about 3 centimeter in about 17 to 20%. Yeah, yeah. So you have to see it, feel that cord-like structure.
His surgery starts from deltoid split. I'll talk about the whole deltoid split. Then once your tuberosities are under your control, that is the main part of the whole thing. First, and fit it onto the head and fit it the shaft and head keeping in the valgus construct. This is how it is. The tuberosities, both subscapularis, supraspinatus, infraspinatus. They are connected and they are put it there in the proper position first, as you can see it here. Then I generally stitch up this fracture in order to get the reduction. And having done that, now you can take this thing from the plate itself. There are holes which are there in the plate. So you will be able to split this up, fix up the pillow split. This is how I do it today. This is now is diagnosed in this bunch, proximal screws, distal screw. And you can see this is the one where the strut screw comes. So if you are doing a 2 windows, you will not be able to put a strut screw because it comes right onto the nerve. So if you explode the nerve, now you will be able to put in the strut screw properly. Otherwise, the strut screw doesn't come. This is exactly when the strut screw comes. So this strut screw, it comes right underneath the nerve. And that's the reason why. That's the reason why. Unless you open up the nerve, you do not do the strut screw. Strut screw is done only if you have opened it, because otherwise, blindly, you will go inside the nerve, damage it. Now, here is a small video. Fracture. This can displace TBR. You can see that very well. Picture position. Mark the radial mark the circumflex nerve, 2 windows. Originally, this is how it is then from back way. With the interior and posterior, here is the nerve which you have marked. So this is how the anterior approach which is there in the deltoid. In the anterior, there is the one, the deltoid raphe which is there, if you can put in a cut. So 2 inches here. So you're making a cut. And then stitch it up here so that it does, your incision does not progress more further distance. So here it is stitched up so that it doesn't go further distance. Now, anteriorly, proximally, you can go on cutting it so that you expose it more proximally. Cut it on the side so you will have a much better visibility of the proximal part of the figure. Now you here it is distally. I have opened. You can see I have made a full incision. Distally I have opened. Look at the spike and I have seen the nerve. And I opened the proximally. This window is the nerve. So when you go down and tease it out, it is inside the muscle. It is not on the bone. Inside the muscle. So when you tease it out, you will be able to see coming from posterior to anterior. You can see this nerve very well there. This is the nerve. Having seen the nerve, now you can hold muscle mass or whatever is the mass having identified, take the nerve out. Now, proximally, after taking the GT switches, you have to keep back the fracture so that now you reduce the whole fracture. If possible, you stitch up this so that the whole fracture has been now reduced. Now having reduced it, this is another case which I am showing again. Same approach, distally and proximally, so that you remain in the center of the humerus. Now you finding the nerve, that is the nerve. So now you are, once you see the nerve, you are more comfortable to operate, that you are not worried about it. And the strut screw also you'll be able to put as I. Now having done that, isolated the nerve, push in the plate underneath the nerve, see that you are on the bone. This is the nerve which you are laid it out. Make the reduction, everything is reduced. PT, LT, or everything is there, and then you start putting the bill of plate. Once you do this fracture will, this gap goes down. Then you can close down the whole fracture gap completely. So you reduced it, you closed it, and now having closed this thing, you reduced it perfectly well. So now the neck is reduced to the chest. And this below state is put in. Now here I am trying to put in a strut screw, which is right underneath the nerve. Either you go to take the nerve physically, as you can see, I am struggling. Part is a little cut off. So you see it now. Now I have displaced it physically, and this is the strut screw I am putting it. Either it has to be distally or proximally, you have to fix the nerve. The strut screw, it goes in. Going in properly. So I know where exactly it's going. If I am putting the strut screw, now you check it up in all directions so that you are not in articular surface. The benefit of course, the posterior surface velocity very good, direct access to the lateral side is the complex nerve issue is the whatever the old fracture is difficult to cannot use the template on the plate because it's the also jig which comes from this below plate is difficult to use it with that shape. So you will have to use individually the sleeve. Otherwise, from a delta factor, you can use the sleeve and you can do the operation. Now here you can see this is Dr. Sanjay take things, then open it up, this is now suturing the rocket is back into the hole. Why I shifted to the deltoid direct approach to the lateral side. PT is not much minimally invasive. What are the results of the good? Once you have done this deltoid split, after 1.5 years, everything is built up very well and the things are in the best position. As you can see, you can see that I'm not penetrating in any whatsoever. But one of the known complications is the current patient. The results of this pillar plate. 35% of non-implant related complaints, implant related 9%. Primary perforation is 14%. Secondary screw perforation after the collapse, 8%. Initial is 8%. There will no debate, 4-part proximal humerus fracture that consistent long-term results after the repair. Unfortunately, at the incidence of non-gaining the rate of movement, most belong then into the stay wire or into the tube. That's the reason why people have practiced that is the philosophy to the right finger. Stopping that complication by the lot of authors in all reports of blocking 10 4 part are not excellent. Final range of movement takes about 7 None are as good as normal side. Ortho postulation, what it is and how acceptable it is. Now, ortho postulation means that if the fracture occurs here, the vascularity is preserved. If the fracture is occurring like this with the peak, then the vascularity is preserved. Like this. The medial aspect of the capsule is the second most important blood supply, a large intact medial spike. And a fragment is an advantageous position. This is what is the Herschel classification. So this is the one which was fracture dislocation, it was reduced, rated, and ultimately the whole thing hits up. Because this is the peak is there, so the vascularity is not there. While if the fracture occurs here, like this, then the Herschel postulation is that the incidence of ABN is very high. And this is the one which is being talked about. But today, people have started doubting because this is the anterior approach and the anterior vascularity. People feel that the posterior vascularity is equally good, and so you can get a posterior vascularity. And that's the reason the ABN rate is not very high. Anterior circumflexion and the secondary branch provide the critical vascularity for the thing. Directly in the region of the deltopectoral approach, in the deltoid groove, in the bicep groove, remain away from the bicep groove because that is also where the whole circumflex artery is being supplied. So this is artery also to remain away from the bicep groove in order to safeguard this artery. To disturb vascularity during surgery, even if the head is vascular after the injury, it can get reversed of blood supply during surgery and end up in. If we decide to operate, what factor gives the better outcome? GT fixation is the most important. If GT does not unite, then the whole result of a fixation is going to be zero. So the GT union is a communicated.
छोटू सो गया ना फिर वो भी रोएगा तू
Osteoporotic bone, GT union is a major issue. So spend maximum time and first take a bite of the GT and keep it under control and get it back onto the humerus. That is the main part of the surgery. And having done that, now you see that this is not into any virus. The head should not be into the virus. And this heart has to be maintained. You cannot really push this person, support it. If she is trying to pull back, you try to push it from the back. Right? From the back, the force is not as much. While if you push it from here, in front, then it's going to be well corrected. That's the reason your fibula. If you put it medially fibula, so you support from anteriorly here, then this will not collapse. This is the basic purpose of this for you. Support from there with the fibula, then it is not collapse. How to achieve reduction of the fracture? What is the role of the fibula in this fracture? We all know about it. This is the fracture. The X-ray like this is very, very misguided. Take a lateral view or a CT, you know it. So this fracture is easy to put in the wire and you will be able to reduce it. So you can do the dose reduction also. You don't have to go there very much. After opening it up, you will be able to. Having reduced this, now you can fix it into this larger position, and that is the best. Even such fracture, you will be able to do it with the joint. Once you put in the plate, valgus. This is what is the one which is recommended. Also, here, if in case you don't get a valgus, if the plate is slightly away, and then you will get a perfect valgus. So it will be able to avoid a var of selection of plate. Intermediate communication and instance. That's what I have mentioned about. Fibula. Orthograph, or nowadays, allographs are available or a metacarpal is available. Medial strut is the one which is most important. And this medial strut will give you a very good fixation and a good, there will be no collapse. And this is the one which we see. A pulse strut graph there. Pulse graph is not all the time very good. Now, done this. He gives this support. Instead of a fibula, he has put in the intra-medullary space. And put this one screw here, one screw there. This also gives it. Only thing, this is the one which will be impossible to do. Ever. So by deltobacter approach, the intraosseous plate has a reduction too. Plate is there. The plate is there. And you can see it. There. It gets the reduction. The reconstruction immediately has helped catch the whole thing very healthy. If you put in the block graph, not a fibula, it has to be a block. Don't put a block like this. Put a block like this. Vertical cancellous block. Exact position of the bone block. This is the one will also which will work. This is the one which I feel. Any questions on proximal humerus? What I have spoken just now. Sangeet, are you there?
Sir. Tanna sir.
Follow.
What I could make out that you took the tuberosity sutures and then tied them on the bone without passing through the plate hole. Was that correct, or you passed them through the plate holes?
So I pick it back onto the bone itself.
So when passing the screws, sometimes you don't face the problem that screw trajectory may cut the screw thread.
Occasionally it can happen. You may have to then put it onto the plate, but it's not all. But once you have put in the stitches like this into the non-communicated good bone,
Yeah,
then it has to go through the plate.
They call it suture bridge technique. Yeah. And Sangeet also, when that slide was shown, he was trying to pass the tuberosity sutures after sliding the plate beneath the axillary nerve. So that puts tremendous stretch on the nerve. So what we routinely do is that we take our tuberosity sutures and pass the sutures through the plate holes wherever we want to pass them. And then we slide the plate in. So sutures are already in place through the plate holes.
Yes, sir.
Any other question?
Sir, which screw you put first in the plate?
Always a proximal screw first, and then a second screw is a distal one, so that you know that you are in the mid shaft of the humerus distally. If you finish the proximal screw and you realize later on that your plate is not centering onto the humerus, then it's not good enough. So one above, one below, see that everything is in the mid shaft. Now you can complete your.
For correction of varus or valgus, like I meant to say.
Sorry?
If you want to correct the varus.
Then as I told you, you put the plate, which is away, which is not on the humerus, but it is away.
Yes, sir.
So that when you put the plate onto the bone, you will be able to correct the virus automatically. I think this is a very well-known technique for the distal areas and proximal humerus.
Yes.
Sir, you can pull on the tuberosity sutures also to give more valgus.
Yes.
And you can use a joystick in the head proximal to the plate. You can pass a K wire from the GT to the inferior part of the head above the plate, because plate is about 5 to 8 millimeter below from top of the head. So you can use that joystick to lever it out in valgus.
BP, tip of the BP is below the tip of the head. That is the one which is most important. It should
And
have-
if your Kelkar guide wire is in the perfect position most of the time, and your Shenton line is intact, it has been restored, Gothic arc has been restored, then probably you are not in varus. If your Kelkar screw is going at the right place.
mistake which is done is you medial communication you disregard once you get a fairly decent reduction. And that medial communication does not hold on. It will collapse. So that medial strut, medial pulse graph is the one which is not, medial strut is more important. And nowadays, as I mentioned to you, even a allograph, which will give you a strut there, which will give you the bone support. That's the one which is going to be as good. Any other questions? Are you there, Dr. Sanjay?
When you treat non-operative, so do you immobilize for some time?
Yeah, because the pain is there. So about 10 days or so, you immobilize it, get a cup and a bottom thing with the shoulder support. And take another X-ray after 10 days time. If the fraction is still reduced, you can carry on. Minor displacement into these elderly people does not make a difference. If you treat conservatively, you will not regret. Only thing is you will have to monitor with the subsequent X-ray. Unfortunately, all fractures cannot be treated conservatively. It is only when there is a debate in your mind. 3 parts or 2 parts. 4 parts, I don't think I will conserve. 2 parts and 3 parts, when you know that in all it needs is a minor reduction, which even you can do a joystick reduction and hold it there, even close reduction. So that is the thing when will succeed quite often. Unfortunately, I think either the financial issues or the wish to make it normal pushes you to do a surgery.
Sir, which are the hello, sir? One question: which is your preferred suture, fiber wire or ethibond?
Sorry,
Sir, your preferred suture, fiber wire or ethibond?
both of them. I don't think there is any problem.
The fiber wire needle is more user friendly, and now with many companies making it Indian companies, then the cost also is not prohibitive. So that needle is superb. It allows you to take that arch easily. Plus, it's less prominent, so knots are less hurting.
The wire is supposed to be stronger than the top. Still, I have to honestly, I feel they are both the same.
Sir, your voice is breaking again and again. Sir, you talked about deltoid split. Can I show the same case? Similar? 4 part, 3 to 4 part done with a deltoid split. Sir?
Please carry on.
Yeah. Here is the one. 9. No.
You have seen a thing.
Now, yeah, this one. This is the one. Slideshow from beginning. Yeah. This, unfortunately, I did not do a CT. So definitely 3-part. Whether it was 4-part, I don't know. Probably lesser tuberosity was undisplaced. And I always take sutures in the subscapularis, supra.
We are not able to see the slides.
I am sorry. Resume share. Yeah. Now it's seen.
Surgical technique review of literature.
ना ये वाला
GT.
एक सेकंड, ये वाला नहीं अभी.
No, sir. अभी तो आपका है. Just seeing your photo.
Just a minute. 3-part neck humerus. Yeah. Now it's in.
Can you put it in a slideshow mode?
Yes,
Yeah.
sir.
Here it is. Yeah. Is it seen now?
Yes, sir.
Yes, sir. Seen.
So 45, female, fresh fracture, diabetic also, and obese. So we decided to treat it by split deltoid or an anterolateral, they call it. So I prefer to get my C-arm from the opposite side. C-arm from the same side is less surgeon friendly. So this is the same position which by and large Saab showed, is a semi-beach position. The whole shoulder is slightly 30-40 degree above. Supine, semi-beach chair position. You must check the X-ray visibility even before you drape the patient. So make sure and mark those things so you don't have to move the C-arm again and again to find out the right place. This is the skin incision, subcutaneous tissue. The moment you see that raphe and split the anterior and the posterior 2/3 of the deltoid, it's almost a bloodless field. A thin fat layer is seen and you can split that with your fingers. Take that away and you can see the bursa beneath there. Then you incise this subdeltoid bursa. This is what we are lifting with a mosquito. And in the proximal window, this is my head end, and on the right side is the elbow. You split this subdeltoid bursa, go beneath there. The conventional wisdom is that axillary nerve is about 5 centimeters from the acromion. Measure that distance, but in about say 17 to 20%, it can be as close as 3 centimeters. So just don't go by the dictum that it will not be within 5 centimeters. Axillary nerve, along with the vessel, is a cord-like structure, and this is the only structure which is traversing from back to front. All other things, deltoid fibers, they are going from shoulder towards the elbow. So this is the only thing which is running transversely, and you can feel it with your fingers. I never put a sling as shown in the book picture there. I just see it and forget about it. The traditional safe zone is 5 to 7 centimeters from the lateral tip of acromion, but it can be between 3 to 5 centimeters in 20% of the patient. This is what this paper said. So again, the head end, this is my subdeltoid exposure. This is the transverse structures traversing here. So I don't really look for the nerve. I allow it to go, my periosteum to go beneath the nerve with a cuff of muscle tissue there. So whatever soft tissue is proximal and distal to the neurovascular bundle, that is not touched. You don't really try to dissect the nerve, and you make a window with blunt instruments beneath this axillary nerve. Then you expose the distal to the nerve, far away from the nerve. Common error while expanding the approach distally is to go posterior to humeral shaft. Our tendency is to go in this direction. So you can use a blunt K-wire tip to find the anterior margin of the humeral head and the posterior margin of the humeral head, which I have marked with the blue ink there. And then you stay in between and expose this deltoid insertion here. You just split it. You don't have to really erase it completely. You go on the bone, subperiosteal bit of exposure so that you know that you are in the center of the bone there. If you extend your incision towards the lateral epicondyle, by and large, you will be correct. And you can feel the anterior and posterior border of the shaft. This is how you make the tunnel beneath the nerve with a blunt periosteum. The one paper said that there is a distance of about 1.3 centimeter allowed when you are passing this. So you can lift the nerve by about half an inch safely without jeopardizing its function. Then you incise the bursa there to expose the fracture. GT fragment is opened like a book to work from within the fracture. In this case, a 5-number ethibond was used to fix the tuberosity. First, the supraspinatus suture is taken at osteotendinous junction. Then you can tug on it, pull the whole thing anteriorly and take posteriorly infraspinatus and teres minus sutures here. So there are in all 4 sutures, one for the supra, one for the infra superior part and the inferior part of infra and the teres minus in 3rd suture, and another suture for in the front for the subscapularis. More tuberosity sutures. You suture the subscapularis also. Pull tuberosity sutures to close this gap in the fracture. See that reduction is correct under image intensifier. If it's not correct, then you take away the tuberosity and start working from this fracture gap from within the fracture here. You can push with a periosteum the head if it's in varus. You can maneuver the shaft, abduct or adduct it to, and part of the reduction is then checked on the image intensifier. Once you see that the reduction is good, then you hold it with temporary reduction with K wires. This is how we started here. This is how it was. We came up to this point. Once we are happy with the reduction, this was the initial K wire holding the reduction here, biting this cortex. Tuberosity sutures are there. You can see that the shaft is away. This line is not intact at the moment. Then you reduce the fracture, pass tuberosity sutures through the plate. So I pass these sutures even before I slide my plate in. If you pass the plate first and then pass the sutures through the plate hole, you are putting too much pressure on the nerve. So pass these sutures through the plate holes before and then gently slide in the plate. You already made the tunnel there. Under image intensifier, you adjust plate height, which should be about 8 millimeter below the superior surface. From this top, it should be 8 millimeter below. And here you can see that the Shenton line has not been restored. This shaft is still medial. So this is the temporary reduction. And once you pass a screw here and pull it with that screw, probably shaft will be pulled in subsequent. Yeah. So we use this screw to reduce. Here it was like this. And tightening of this screw is done under image intensifier control till it's getting reduced. And final picture, it's completely reduced. You have to check the fracture alignment and plate position on the lateral view, which Saab was talking about, that in AP as well as on the lateral view, both plate has to be centered. This will not do. Something like this is a poor reduction. So you have not fixed the distal fragment. You can still undo the reduction and translate the shaft anteriorly. Another point, if your calcar screw is going at the right place and this line, Shenton line has been restored and the Gothic arc looks good, then probably you are not in varus. Your reduction is good. More screws there filled up in the remaining holes. This is how the final suture construct will look like. And this is how she is. 3 months post-op, 1 year, 7 months. This is the function, and 9 months and 1 year. Now is almost 3 years. She has got a full range of motion, no limitation of external rotation also. Yeah.
Fantastic, sir.
Yes. So I find it's more biological approach, and you can do almost anything through this approach, even 4-part also. You from within the fracture, you can work. You have to get familiar. So start doing it for isolated GT fractures first. The advantages and other thing I think Saab has talked about. Yeah, he has covered all this. This is the post-op protocol. You give a sling. Passive range of motion, I mean, relatives, they are taught to do passively gentle external rotation up to almost 20 to 30 degree of passive external rotation. If you maintain external rotation, by and large, you will get a finally very good range. Active range of motion is started around 6 weeks, and standing exercises are not started before 3 months. It will take almost 6 months, 9 months to get the final result. Any question?
Sir, delta pectoral approach is better or lateral deltoid splitting approach
I'm
is
hooked
better?
on to deltoid. So
Yeah.
if it's 50-50, I'll use a anterolateral split deltoid.
We are also using deltoid splitting approach, sir,
Yes.
and feeling so much comfortable. Thank you, first.
Only in case of fracture dislocations,
Yeah.
you have to go for deltopectoral.
There is no choice. There is no choice.
No choice.
Tanna sir, you are taking something, or I show one more case?
Shailesh is here.
Shailesh is here, then we start with Shailesh. Yeah.
So you can hear me? Dr. Shailesh Pai.
Good evening, sir.
Good evening.
I think I'll introduce you Shailesh Pai. First question I want to ask you, Shailesh. How frequently you do a Philos plate for the 4-part humerus fracture?
Hi, sir.
I
To
have
answer,
asked again and again, as you know. But this is a new audience, that's why I'm asking you again.
yes, sir.
Have you given up Philos in presence of a multi-lock nail?
Yes, sir. So in today's age, if I want to answer this question, we in our institute, you are totally given away with Philos for any 2, 3, or 4-part fracture proximal humerus. So we only do a multi-lock nail in any acute scenario. The only contraindication may be if the canal is too narrow, which is extremely rare possibility.
Dr. Pai is from Bangalore, Dr. Shantaram's Institute, and he has changed the whole approach, which I think I asked this question to Ajit, and Ajit said that we were all doing philosophy till the time Dr. Shailesh Pai introduced this nailing, and now they've changed the nailing. So here it is now a totally different approach to the 4-part humerus. Shailesh, all yours.
Thank you very much, sir. Thank you for giving me this opportunity. So, so my talk today will be on use of multi-lock nail for proximal humerus fractures. I was actually not very much aware of the entire process, but in a way, I'll be dealing only with the nails of how to use this nail in any fracture. So some of you might have a doubt as to why we need to be considering a different implant when Philos plate is there, which is considered a gold standard. But if we sit back and look into our fracture radiographs, we do realize that we are missing on certain aspects. Now, for example, this was a mid-50-year-old patient who came to us with a 3-part fracture, which was proved on a CT. It looked 2, but on a CT, it is a 3-part fracture with the GT being a separate fragment. And this is what we were able to achieve. We reduced and fixed it well. That's what we thought, that we have got all those things. That is what is mentioned for a good outcome. That is getting a good neck shaft angle, getting the tuberosity way below the head, getting the calcar screw. All those things were achieved. But in 3 months follow-up, this is what the patient ends up with. So what we realize is that there are certain things which are not in the surgeon's control. Now, no matter what we do, the patient might not get the full benefit of what the surgeon has achieved. Now, one other example, again, mid-50-year-old patient. This is what we achieved, and this is what it ended up with. Now, we can call this union, but we all know that this is not the true union that we wanted. Now, this is a malunion in some varus. So the secondary displacement, that is, things slightly drift after we have ended the surgery. Now, this is not under the control of the surgeon, unfortunately. So again, the patient will not have a full functional outcome, although the surgeon tried his best in doing what he can do best. This is the third scenario. I'm pretty sure all of us in this Zoom meeting room do have faced this scenario where we do see 1, 2, 3 screws become intra-articular over a period of time. Now, again, not much of an issue, but only thing is this is only going to delay the rehabilitation of the patient. In the sense, these screws were not intra-articular on day one. The surgeon has taken through the complete range of movements, intra-op, even using fluoro many of the times, and these screws were all right. But the collapse which happens, the axial collapse which happens, has to happen in almost all 4-part fractures, and hence some of these screws become intra-articular. And since we see these patients on a monthly interval, it's only going to delay their rehabilitation, because the moment this becomes intra-articular, it is painful and they do not take the take the shoulder joint through the range of movements. And that's where, again, the patient loses out on getting an early functional outcome. So these are things that make us think that, okay, Philos does a great job. I'm pretty sure all of us have used enough Philos for treating all these fractures. But then in certain scenarios, things are not good. And that's why we should start thinking whether there is any other implant which can maintain the reduction that the surgeon achieved in drop and give the full benefits to the patient, thereby achieving the complete functional results. And that's where we need to start thinking on the other aspect, which is the nailing. Now, nailing, unfortunately, has got a very, very bad name in treating humerus fractures per se, not just proximal humerus, but even humerus shaft. Now, that is because of these disasters that we had with the previous generation nails. I mean, very, very few went on to unite, and even those who went on to unite had a very painful shoulder. So all of us have this in our back of our mind that nailing in proximal humerus is equal to disaster. And that's why we don't consider nails. But thing is, many of the things have changed with times, and there are newer generation of nails which have taken into consideration all the problems that were there with the previous generation, and the design itself is changed. Now, if you want to list the problems that we had with the previous generation nails, the biggest issue was that the entry was straight in line with the footprint of the cuff. Now, that is the amount of damage that we do when we try to either ream or pass in the nail. Now, and we all know that the footprint of the cuff is right there. So definitely, no matter what, some damage does happen to the cuff, and these are the painful shoulders. So a patient is not happy at the end of even the union, and hence the surgeon also will not be happy. The second issue was with regards to reduction. Now, the nail was having a lateral bend, so it's a little lateral entry point. Now, with our understanding of even the subtrochanteric and proximal femoral fractures, we do know that the more medial entry we take, the lesser is the chance of varus. Now, same thing if we extrapolate to a proximal humerus, this nail by design, the previous generation nail by design was having a lateral bend, and we were taking lateral entry point, so it was tending to drift into varus, and varus in shoulder is definitely not good for the patient. And the nail was sitting in the place, in the bed, where the tuberosity should come back. And again, we all know for a fact that in a shoulder, unlike in a proximal femur, unless the tuberosities heal back in its anatomical location, the patient will not get a complete range of movement. So that is the dictum in shoulder, and hence, since the native location was being occupied by the nail, the tuberosities could not sit back in its normal location. One other issue was with regards to the cutouts that happened. Now, this was especially enhanced in osteoporotic fractures, the elderly patients who came with 2, 3, and 4-part fractures, because the bone quality was not great, and all these screws were more or less uniplanar, and hence significantly higher incidence of cutouts. Now, these all have been solved, plus some additional design changes have also been made, and that is what this current generation nail is all about. It's called the multi-lock nail. What are the changes? The entry point is much more medial, unlike in the sulcus, it's right in the axis of the shaft. Now with this, couple of things automatically happen. Number one, we do not damage the footprint of the cuff. We are much more medial to that, so we can take an incision of the supraspinatus tendon in line with the fibers, retract that and take a direct entry over the bone. So hence we will not damage any part of the cuff. And this nail being much more medial automatically tends not to drift into varus. So that's again an advantage that we have. So that's the current entry, much more medial, not at the footprint. And here we see the tendon. Under visualization, we can split the tendon inline and take the entry point. Tuberosity repositioning is much more easier now because the nail is occupying a medial space rather than lateral space. So there is enough room for the tuberosities to fall back. Plus the previous generation nail had this bolt, which was again an issue because many times when we are inserting this bolt or screw, the tuberosity is to splinter. We all know the tuberosity is a very, very flimsy bone, and intraoperatively splintering chances were high. Now the current generation design of the bolt is, we can see the undersurface is tapered, so it lacks more or less like the washer effect. So the surface area is increased and hence the pressures are decreased, and hence intraop splintering does not happen. Plus one additional thing that is also seen is one thing that we all loved with the Philos plate is that we could suture the tuberosities back through the plate with the holes on the plate. Now, same thing has been incorporated in these screws. These screws have these holes through which we can suture the tuberosities in whatever fashion that we want. So these are, again, like we all know, proximal humerus fracture surgery is more or less a soft tissue tensioning surgery. Unless the tuberosities are really held in its position, functionally the patient is not going to do great. So we can suture this using the same techniques that we do with the plate. The cutouts, again, which was the issue with the previous generation nail, now has been countered with this screw-in-screw design. So this screw is tangential at 30 to the first screw. So the first golden screw goes through the nail. The second screw goes through the screw outside the nail and takes some purchase in other part of the humeral head. And this trajectory is fixed at 30. So any physiological force which is perpendicular to this screw is not perpendicular to the second screw at the same time, and hence it provides a significant cutout resistance. So much so, biomechanically it is proved that this one screw-in-screw construct gives us as much cutout resistance as 4 Philos locked screws. So the maximum screws that we put in Philos is about 8 or 9 maximum. Recommendation is anything above 5, but maximum we can put is 8 to 9. And here, just by putting in these 2 screws, we are going to achieve as much stability, if not more, because there are more options in the nail now. And one other thing that is there is this polyethylene bushing, which is inbuilt within the nail, and hence these screws can't go in and come out. So all these problems that we have with the plate of screws migrating post-operatively does not happen with the nail, again proved beyond doubt in biomechanical studies as well as in clinical studies. So what actually happens is an example of an expert tibial nail in which the screws can just go in and walk out where if there is not enough purchase. Now, this is with most nails that we know in current design, but with a multi-lock, we can see this polyethylene bushing lined within the thing. So the screw can't be pushed in. It has to be threaded in, it has to be turned in. Now, when we are threading it in, the bush actually expands, and once the threading is stopped, it collapses on that, giving it the purchase. Now, with this, 2 things happens. Number one, this screw cannot go in even a millimeter inside or come out even a millimeter. So that is an advantage that we have. Number 2, the screw has an inherent purchase within the nail of its own. So no matter what the surrounding bone is, even in an extremely osteoporotic bone, it is not dependent on the surrounding vicinity of the bone. So that's an advantage that even in the most osteoporotic fractures, we can consider osteosynthesis using this particular implant. So once it goes in, as we can see, no matter how much force we use, it just can't back out. So that's the advantage that is there with this design of the nail. Plus, on additional screw, 2.5 millimeter locking screw goes through the first first bolt hole, and goes outside the nail and gets locked within the first screw. Now, this is, like I told, at a tangent of 30, and hence there is no way that any physiological force can back out both the screws at the same time, because whatever is perpendicular to first screw will not be perpendicular to second screw at the same time. That's
the tablets, variable patients. Upper line, like
So this is in just is what is the difference between a nail and a plate. Nail is trying to hold the head from the side, and with each abduction adduction movement, the grip is going on loosening. Whereas the nail is taking its entry right through the head, and hence this is acting as one single unit. The head cannot act separately away from the nail, and that's the entire difference of why things are behaving differently, and how do we achieve a better stability with respect to a nail as compared to a blade. So to brief, what are the different things that the current generation nail is? One is it is a straight nail design, so hence a much more medial entry point. There is a screw in screw option that we can put to overcome the varus cutout forces. There is an ascending screw, which is the calcar screw option of the Philo. Same thing, same design, same trajectory has been incorporated in the nail. Now this again gives an advantage in especially 4-part fractures to overcome the varus forces. Then all the locking options, whether it is a proximal or distal, are multiplanar, in all are in different planes. There is polyethylene bushings within the screw holes, so this gives inherent stability of its own, and there are holes within the bolts to which we can suture the tuberosity. So if you can see, whatever the problems that we had with the previous generation nail has all been taken care of. Plus additionally, all the advantages that implant per se had all has been incorporated in the nail. So now we have the best of both the worlds, and single implant which can do all the things that we actually desire an implant to do, right? So how do we do it? So surgical procedure, just to brief, the technique is not much different. The positioning we can do either in a beach chair or in a supine position. There's no difference whatsoever. So in whatever way the surgeon is comfortable, he could do it. There's no advantage of one over the other. The trick in any proximal humerus surgery would be an easier option would be to get the C-arm from the opposite side. Now, not just for nailing, even for plating. By doing this, we are saving time and we are saving a lot of hassles in drop. Okay, so because if the C-arm is coming from the same side, at least 1 or 2 personnel should be moving out of the same. So the C-arm comes from the opposite side. Now, even before you paint and drape, we can see whether we get all the information. So this is how the C-arm comes in. So this is the AP that we get. Again, this is not a true AP. To get a true AP, all we need to do is tilt the arm, C-arm 40 degrees, and this is the true AP that we get, where we see a clear space between the glenoid and the humeral head. Now, this is the view that we need to get to be very sure that the screws are not penetrating the articular surface. And when we tilt it to the other 40, so we get this so-called Y view, where this is more or less like a lateral view. So we have an arc of 80 to 90 degrees. That's the orthogonal view planes that we are talking of. And without moving the arm, without anyone moving out of place, just the machine can come in and go out and give us all the information that is required. Now, this will be very, very helpful if it can be done. Now, provided this this table doesn't have rods at the end, of course, but it will be very helpful whether we are doing a nail or a plate or any proximal humerus fracture surgery for that matter. So, and how introp we do it now, for example, so this is a 42-year-old gentleman with a 4-part fracture proximal humerus. So this is confirmed on a CT. So this is the incision that is used. Now this is in between the deltopectoral. Now this is the left shoulder, the coracoid process and the acromion. So the deltoid split approach is little more lateral to this, little more posterior to this rather. Whereas the approach which is described is the true anterolateral approach. Now this approach is along the anterior part of the acromion going down. Now, this is a very, very versatile approach. We can use this in plating, nailing, any approach for that matter. And this one approach gives us significant advantage. In the sense, if you're doing deltopectoral, we know the amount of dissection that is required. And when you're doing a deltoid split per se, we are actually limited by the vision that we get. So it's easier to do a deltoid split in a 2 and 3 part. Little tricky in a 4-part, you will require little experience, but very, very nearly impossible if it's dislocated. But with this approach, no matter whether it's an anterior dislocation, posterior dislocation, 2, 3, or 4-part, even head split, all of this could be tackled with this same incision. And for whatever reason, introp, if surgeon feels that he has to switch over to a plate, all he needs to do is extend this incision. The continuation of this is the anterolateral approach of the Henrys to the arm. So we can put in the longest plate possible also just by extension. Of course, the axillary nerve needs to be visualized in that scenario. So the approach is pretty simple: 2 to 2.5 centimeters proximal to the tip of the acromion, coming down about 3 to 4 centimeters. So after the skin is incised, we need to split the anterior and the middle fibers of the deltoid. There's a nice raphe which is seen, so we can split it in line. So the plane will be between the anterior and the middle fibers of the deltoid. Once we do that, we are straight off on the capsule and the underlying structures. The next step is very similar to what we do with the philos, that we can take a bite at the tendon bone junction interface, which has the best tissue. So double bites preferably, hold it with ethibond or fiber wire. This is the tuberosity held under our control now. Same thing we can do with the lesser tuberosity subscap junction and under our control. Now, with both of these under our control, we need to, with both of these under the control, all we need to do is to see is whether they are freely mobile and totally under our control. Once that is done, we can leave the tuberosities out at that point of time and just think of the head, get the head aligned with a good neck shaft angle. And once we achieve that, we can transfix the head very anteriorly onto the glenoid. So imagine in a 4-part fracture, we have these 4 parts. So don't bother of the greater and lesser tuberosity at that point. Just think of the head, align it to the glenoid and transfix it onto the glenoid with the anterior wire. So once this is done and we take a good entry and pass in the nail, 2 of the 4 parts are taken care of. That is, the head part is taken care of, shaft part is taken care of. And then the tuberosities have enough room to come back and fall back into its place because they always belong there. So that is the advantage if you compare it against the philos, where all the things need to be packed in its perfect location, put in multiple wires, and then the plate has to be put, which is actually challenging again because many times these wires will come in the way. Whereas in a nail, we don't need to bother the tuberosities at this stage. So once that is done, take a good entry. The entry is, of course, confirmed under the C-arm. So this entry is taken in line, like what was described, just in front of the acromion. This is confirmed on the C-arm. So at this stage, the tuberosities are out, as we can see, and even the shaft is actually not well aligned, but doesn't matter. As long as the entry point is good, we take an entry reamer of 10 millimeter and take the entry into the head. Once that is done, so we can mount the nail and pass in the nail. So this nail is passed manually. We should not be using blows for this because there are chances we can burst out the head, because many a times head will be a very, very small chunk of bone. We have all seen that, right? So we should not be using excessive force. It should easily go in, and it will go in. So once this is done, now the head and the shaft gets aligned. So, and there is nothing coming in the way of tuberosities to fall back to where it belongs. So that's the advantage. So now, as you can see, head and shaft is aligned. So get back the tuberosities, pull it back. So great tuberosity is usually superior and posterior. So we can pull it inferiorly and anteriorly. Same thing, lesser tuberosity is usually medial and inferior. Get it back, and the bolts can be taken. I mean, bolts are taken through the tuberosity. So 1 or 2 bolts go through the greater tuberosity. And no matter what age, this is not the only thing which is holding the tuberosities. We need always suture the tuberosities back onto each other plus onto the bolts. So this is how the bolt is put in its place. So again, surgeon has 3 different options: one straight lateral to medial, one anterolateral to posteromedial, and third one is posterolateral to anteromedial. Any of the 3 or all of the 3 can be put depending on the fracture configuration. Leaving space for the second screw-in screw also if desired, which will be required in most 4-part fractures or osteoporotic fractures. So that's the trajectory of the second screw, that is the screw-in screw, which we can pre-decide beforehand whether we want to go posterior, anterior, inferior, superior, whatever range that the surgeon wants. Once that is done, other bolts are also put in. All these bolts can be put in through the jig. This is how it looks at the end of putting in all the calcar screw and all these bolts. And since the calcar screw is put in place, and this was a young 42-year-old gentleman, there is no need of an advantage of putting in the second screw-in screw. But if the surgeon wishes to, he could always put in. So this is the AP and the lateral views seen intra-op. So after this, again, same thing like philos, no matter what good purchase we get through the bolts, don't be dependent on that. Why? I will come at the end of this talk. Always suture the tuberosities back, and that is also recommended that the screws are not only good enough to secure the tuberosities, we need to suture them back to the bolts and onto each other. Now here we are suturing the greater and the lesser tuberosities onto each other. There should not be any rent left after we do this, and take it through the complete range of movements intra-op, just to be very sure that there are no loose sutures that we have put. If it is the case, we can always augment that particular area. So once that is done, we should ascertain ourselves that nothing is loose, and we can mobilize these patients pretty early. So take it through the complete rotations and abduction in trop. That's at the end of the surgery where all things are put back, and then we take it through the range of movement. So that's how it is done. This is the immediate post-op X-ray. Now, so just to show some case examples of how we can use this for the treatment. Again, 4-part fracture. Same principles, get the neck shaft angle right, get the tuberosity under the head, and then the implant does its job. This is immediate post-op. I've kept the timeline open. So this is 2 months follow-up X-ray, and we can see the range of movements at 2 months. So these patients get back most of their movements, in fact, 95% of the movements by 2 to 3 months. They get back the rotations pretty early. We need to tell them that they need to be getting this back. Otherwise, they won't be. So we need to tell them and even their physiotherapists that this is what we are planning and this is the timeline that we need to work on. So what about elderly patient? Now, this was a 6 weeks neglected fracture, not rather neglected. He was taking Ayurvedic treatment for the same. He was a 70-year-old gentleman who was taking this. It was a posterior dislocation, 6 weeks, presented to us. Again, same thing, reduction. With the same approach, even though it was posterior dislocated, we were able to fetch it out and pass it in position, hold it with the screws. This is on union, and that is the range of movements at the end of 3 to 4 months. Head split fracture, again, a little difficult thing. We all agree that it's tough to treat these fractures, but as long as we can get a good reduction, the implant will serve us very well. Now, this is a pure head split in a 34-year-old gentleman, software engineer by profession. It's a true head split through and through. Again, the only difference will be both of these splits part need to be held onto the glenoid with wires. So we can see 2 wires instead of the regular one, and then take an end. And once the first, we can take off this wire. So this is his intra final picture. That's his immediate post-op, and this is at 3 months. That's his range of movements at 3 months. I do have his consent for showing his face in the video. That's the range of movements at 3 months. So the implant serves us very well as long as we can reduce it well and hold it with the implant. So that's the advantage, unlike most other implants in proximal humerus fracture surgery. Again, segmental fracture, difficult proposition. I'm not saying impossible, but little difficult to plan it with a plate because both the fractures have to be considered simultaneously. But when we are doing it with a nail, the distal fracture is nearly obsolete in the sense we don't need to plan too much for that. This was a 4-part proximal fracture and a segmental shaft. So get the reduction right in the proximal part. Distal one usually aligns by itself when we pass in the nail, and both these are multi-angular locking options distally. Proximally, get the good neck shaft angle, get the tuberosity under the head 8 millimeter to 1 centimeters, and as we can see, it's good union at 3 to 4 months. That's his range of movements at the end of his union. 78-year-old gentleman, very high fracture, not really anatomical neck, but somewhere in between surgical neck and anatomical neck. And on CT, we can see significant comminution, both medially as well as anteriorly. This is very common scenario that we see more and more difficult fracture patterns. So many of us might contemplate replacement, but this implant serves as well as long as you can get good reduction. Again, same principles. Like I told, the nail doesn't depend on the purchase in the bone. So get a good entry, pass in the nail, and get that suture anchor the tuberosities well. So this is what we ended up with. That's his union. And what we can see is whatever we ended with respect to the neck shaft angle, the same thing is maintained. Now, this does not happen in the fillers, especially in osteoporotic or a 4-part fracture. We do see some drift happening. The drift can be minimal, in which case the surgeon is lucky and the patient goes on to malunite. But if it is over and above what is optimal, it goes on to varus collapse, right? So that doesn't happen with the nail. It's the same thing what we achieved. Number 2, the screws don't back out or go in. So whatever we ended up with remains the same. So this is it. At intra last picture or immediate post-op, and this is at 5 or 6 months. There is nothing happening with respect to the implant, which is a huge bonus that the surgeon has. So this is range of movements at the end of 5 months. Again, very high neck fracture, young gentleman, anatomical neck fracture, late 30-year-old gentleman. Anatomical neck fracture, very difficult to treat with fillers because the number of screws that will really hold onto this head will be very minimal, 1 or 2 screws at the max. Whereas with the nail, since the nail is taking its entry through the head, it will work as one combo unit. So we have a medial combination and an anatomical neck. So pass in the nail, pass in the screw and the bolts, and this is in immediate post-op X-ray. That's his union at union 4 months. And that's again comparison. What we ended up with is what it is. So even though there was so much comminution, there is no secondary varus drift happening and nothing is happening to the screws, no backing out or going in. So this is, I'm pretty sure all of us appreciate, it will be very advantageous to us. So that's his range of movements. More combination, again, tough with a plate, not impossible, but this is more or less a global combination, anterior, posterior, medial, as well as lateral. Same principles, that's the union. Elderly patient with combination, same principle, get a good neck shaft angle, and we can see that the bone unites around the nail. That's the range of movements. And more combination, significantly more combination, open fracture, but same principles of getting a neck shaft angle, getting a good tuberosity under the head and passing in the nail, and the bone does heal around it. So that's the advantage that we have. So that's the range of movements. So that's the clinical series, but what about the literature? Does the literature support this? Very much. Now, to a fact that post 2017, almost all articles have clearly proved the advantage of a nail over the existing gold standard, which is the plate. There is not a single literature now which is telling that the plate is doing as good as a plate. Now, this is 2021 RCT being carried out, which clearly shows that the complication and revision rates were much higher in the locking plate group, right? That is because of the secondary drift that we just spoke about, always leads on to secondary surgeries in these patients. That does not happen with the nail. So as long as we get a good reduction, it does a great job in holding on to the reduction. Again, in 2021 article clearly showing that there's huge advantage of a nail compared to a plate. This is one other article, which again is in 2021, showing that the results are much superior with a nail. So yes, there are enough in the literature, but what about the complications? Now, I can't be telling only the good things and not show the bad things. Yes, all of us agree that there cannot be any surgery without complications. And when we look backwards, we do realize that during the journey of this, we may say maybe because of the learning curve or whatever, but there are complications. And most of these complications, if we really look into, are surgeon-based complications and not implant-based. This is one of our initial X-rays where we were so happy with the amount of purchase of the bolt within the tuberosity that we did not suture the tuberosity. And at the 3-week follow-up, we see the tuberosity is flying out. Of course, the resolution was simple, that we had to go in back, remove these bolts, put this tuberosity back and suture it back and put the bolts in. But this patient did require a second surgery, which could have been avoided with a simple 5-minute extra job that we could have done on day 1 of the surgery. So even the recommendation is clear cut, no matter what is the age. Even if you get a great purchase, the tuberosities have to be anchored back through the holes of this bolt. So that is mandatory now. And this was our first and the last of this type of a complication. Never ever we had this after that, because we have been doing what has been recommended after that. This is one other case. This was again during the peak of COVID that we had. We had an elderly patient. She was nearly 80, if I'm not wrong. Segmental fracture, head split, and shaft fracture. Now we didn't have much options left. So we planned for a nail. Now, only issue is we did not have all the sizes of the nail. In the sense, the nails comes in 15 millimeter increments, but after 240, it comes in 30 increments. So we did not have the intermediate 255 nail. And this is exactly what the patient wanted. So she wanted 255. 240 would have been too short. It would have ended here, and it was too close to the distal fracture. And 270, as we can see, it's proud. So what we thought was, it's okay. I mean, since things are being held, we will let this, because we have seen that the union is pretty early in this patient, 2 to 3 months. So at the end of 3 months, once this consolidates, we can remove this nail, and if required, plate this shaft if it is not healed. That was our plan, because we were not left with much other inventory during the COVID, and we were not getting any supplies. This is at 3 months. As you can see, good union at both the proximal as well as the distal shaft. And as we wanted to get her for second surgery, but this patient was pretty happy. This is because this nail is in front of the acromion. So they get decent range of abduction, even though it is proud. I'm not saying it has to be kept proud, never ever. But this patient has good abduction. This is the amount of abduction she has, but she doesn't have even 10 degrees of forward flexion. And trust me, she doesn't want any surgery because it is painless and she's happy with what she has. She did not undergo the second surgery. But yes, it was our fault in not having all the inventories that ideally we should have been prepared for. The next complication is one of infection that we had. So this was again a late 40-year-old patient, open fracture. We thought we did a great job and all the parameters were right, but unfortunately ended up in infection. And as we can see, almost everything collapsed. So this patient was advised a second surgery, not turned back till now. I'm pretty sure would have gone to some other surgeon for a resolution. So one last X-ray I would like to show. This was a 57-year-old female patient who had fractured proximal humerus, a very bad open. This was a road traffic accident. Luckily, her artery and the nerves were in, the brachial plexus was intact. Artery was also intact. So debrided, and we ended up with this. So this is at 3 months where we were very happy with the union that she had. Good neck shaft angle, and the tuberosity looked pretty decent, and she was also doing pretty well functionally. When she came back to us at 2 years, this is what she has radiologically, but all of us know that even in shoulder is not equal to even in a hip. So this is her range of movement. She's pretty happy with that. Painful, but she doesn't want any secondary intervention as of now. But yes, this AVN is one other complication that can happen because of the injury per se or the surgery, I might say. But this is the only AVN that we have in our series. So these are all the complications that can happen. But if you see clearly, each of these complications are definitely surgeon related, because infection is again something to do with the soft tissue dissection handling that we do. GT cutting out was again a surgeon mistake. The nail proud was again a surgeon mistake. So the implant related complications that we see with the plate, like the screws backing out, screws going through, varus collapse, all those don't happen with the nail. Now that's the advantage, that one significant chunk of complications is taken out of equation. So this is one other fracture, one other complication I might say, that 40-year-old patient who had this proximal humerus fracture, we were all, pretty sure that we could nail this. So this is what happened, that she has a very, very tight canal. So the short nail is, small nail is 8 size diameter, and this is 7 diameter. This was not going through, and if you can see clearly, there is a splinter going in the distal part, and this is getting distracted here, right? So this is what we ended up with. Told the patient that you might require to do bone grafting at 6 to 8 weeks. This was at 1 month follow-up. Nothing is happening there. The splinter is healing, fortunately. And at the end of 3 months, what we see is good union. Now that's again little advantages, that the nail was holding its ground and there was no secondary collapse happening. Otherwise, this implant would have failed. So luckily for us, this went on to good union and the patient did well. So this is part complication, not a real complication. So these are all the different issues that we created and we ended up with, I might say. So so take home message, most proximal humerus fracture surgery, we all agree, is a tough fracture pattern, and we do end up with many problems post-operatively. But the most of the problems that we have with the existing gold standard related to fracture personality, like combination, 4-part fractures, head split fractures, in which case the gold standard will not work great. Now these are not a concern with the nail. Of course, iatrogenic complications has to be avoided. We should bury the nails. The tuberosities have to be sutured back. We need to get in adequate screws, get in a screw if required. All those things has to be done. Reduction paramount. No, there cannot be any functional good outcome with the bad reduction. So the implant will not do anything in that aspect. The role of the implant is only post-operative and not intraoperative. All intraoperative things has to be done by the surgeon. And of course, things are looking very good. And it's been there in the Indian market at least for the last 5 to 6 years. And all over globally, I must say, enough surgeons who have been doing this and getting great results. But really, to challenge the gold standard, we do require a multi-centric, multi-surgeon studies on a definitely much larger scale to dislodge the current existing gold standard, which is the plate. So thank you very much, sir, for the opportunity.
Thank you, Silas. It was a wonderful talk. And you have really broken so many myths. And as I said, every time I heard you in the meetings, my impression, this time I think you had all the time in the world. So you've been able to show all your tricks and complications and everything. Thank you very much. Any questions to Silas? I'm sure there will be many questions.
Shailesh.
Yes, sir.
Some of the fractures where anatomical neck was involved and that head fragment was really very tiny, 10 mm of proximal part of the nail going there, doesn't it laterally cut through as happens in the hip, lateral wall cutout?
Correct. So that is the risk that we always need to remember. And the precaution to that will be, sir, we can valgize the head. The advantage that we have in a shoulder as compared to a hip is that we can actually valgize the head. So if the fracture is little more medial, the moment you valgize the head, the fracture becomes more lateral.
Then you are going through the articular surface?
Yes, we are going through the articular surface. So we need to be at least 8 millimeter medial to the medial most fracture line. Now, why 8 millimeter is because once you put a guide wire, the reamer, which is the core reamer, is 10 millimeters. So it is chewing off 5 millimeter of bone on either side of the guide wire. So we have at least 4 millimeter of boundary. So yes, we are going through the articular surface, but this particular articular surface will be articulating with the glenoid in more than 120 degrees of abduction with internal rotation. So if my patient of anatomical neck part is having 120 degrees of abduction, I think I'm pretty sure most of us would be happy with that. And they don't complain of pain. If they do, I'm pretty sure that will be an excellent result for the patient from overall fracture personality point of view.
Yeah.
Yes, any questions? Sangeet,
sir.
Like to talk or say any experience of a nailing?
Yes, sir. The nails are straight nail. That is what is the difference. And the other advantage why they don't cut out is because of the bolts. They have a locking inside the nail with the help of a poly, so that cutout is not seen at all. So the outer cortex, like you can reinforce with a screw and screw. Second endpoint is the poly, which is inside the nail. So these two endpoints, they don't allow the nail to cut out. And being straight nail, this is the third generation nail. The earlier nail where there was the entry point was lateral. So these are straight nails in line with the medullary canal. So the chances of collapse or those going in varus are very less and that is maintained throughout the healing. Shailesh will agree with me what I'm saying.
Very true, sir. These are the advantages that why this implant is behaving better than the other implants available to us.
Shailesh, the Indian copies of the original synthesis nail, do they give you poly on screw in screw design bolt?
As of now, no, sir, because when I spoke to these companies, what they told was they require a special permission or what do they call that? Some special
copyright.
Copyright. Not copyright. They don't run copyright. But for selling it, marketing, they require some special permission for that. And once that is done, this has to come in a sterile pack. Each nail is a sterile pack. And the company's concern is once they do that, the Indian surgeons won't wish to use it, because if they open a nail, then you have to use that nail and you can't exchange. So they have a little bias, thinking that the marketing might not be easier with Indian surgeons if that comes in sterile polypack. So they have devised an alternative mechanism, which I'm not very sure because I don't have personal experience with that. They have got threads within these nail design in which the bolts interlock to a certain extent. Now they claim it is similar, but I'm not sure there are any biomechanical studies on this, nor do we have any experience, or there is enough studies being done to see how they perform as compared to a poly. But given an option, definitely the poly is working.
Shailesh.
Yes, sir.
That locking head screw, which you are talking about, that the bolt has threads and the inside in the nail also has a thread where it gets locked, was given by Stryker in its interlock nails. And I have used them and it works really well. That bolt has far more purchase than other locking bolts. It may not be as good as the poly.
Yes, sir. So that's what. So I don't have any experience with that. So they do claim it is equivalent. Yeah. So
the of an endpoint.
Sir, you are not audible.
Oh.
If you want to say something?
Yeah.
The feel of the endpoint when you tighten the screw is not comparable with any of the, even the locking bolt. When you have a bicortical purchase, it is totally a different feel, and you have to use it to believe it.
That feel actually made us not to suture the tuberosity in the first case that we showed, sir. Yeah.
Thank you, Sailesh. Since there are no more questions, thank you.
You, sir.
You are coming in and really teaching us this new thing which is coming up. Thanks a lot.
Thank you, sir. Pleasure.
If you want to present now, your thing.
Yes, sir. I'll be presenting a deltopectoral approach and the tricks which are required when you're doing a plating, if that has not been covered earlier. I joined late, I'm sorry for that.
Even if I have spoken, you will add up something, I'm sure.
Okay, okay, sir.
So by experience, you will be able to give something more.
Is my screen visible?
Yes, sir.
So we will be discussing plating. Sir has already covered about the deltoid split and how you do a plating by a lateral approach. And I will be speaking on the deltopectoral approach with videos and operative techniques and tricks, how to get the best reduction. So it is all intraoperative and it is a case-based related. So these fundamentals are important when we do a good proximal humerus plating, wherein the important part is the reduction, which will help whether you are nailing whatever approach you are taking. But these are the fundamentals which are essential. A good medial support and the implant factors, whether it is related to plate, how should be the plate, how many screws in the proximal and distal fragment, and how do you take sutures, as you can see here, which have been used in this plate. Now, the reduction is the key. Now, when you are using a simple technique where you put a percutaneous screw for fixing that, or you are using plating, or you are use a nailing, I think somebody is talking. Nitin. Nitin,
Yes, sir.
mute yourself.
Yeah, I'm muting. Unfortunately, sorry, sir. There is some problem.
There is an echo. Probably you're using two instruments. Close one of the instrument. So whenever we consider reduction part, the most important is Sagar. So, Sagar K, please mute yourself.
Sangeet, I have muted all. Sangeet, you will have to unmute yourself first.
Yeah, I got it, sir. Now you can see the on the left side, the picture on the left side, the Gothic arch is not maintained. It is broken because there is no reduction here. And after the reduction, you can see that Gothic arch is maintained. So maintaining that Gothic arch is the most important part whenever you are seeing a true AP view. And the true AP view is the one in which you are seeing the glenohumeral joint. And that is what you should aim at when you are getting a proper reduction. Now, reduction of a 2-part, reduction of a 3-part, and reduction of the 4-part are entirely different. Now, when you are doing a 2-part reduction of the proximal humerus, the head fragment remains constant in relation to the glenoid. So whatever is a displacement of the shaft, because both the tuberosities, that is the subscapularis to the lesser tuberosity, and the supraspinatus, infraspinatus to the greater tuberosity, they remain attached. Unlike a three-part, where the greater tuberosity and the supraspinatus are separated. The proximal fragment rotates internally because of the pull of the subscapularis. So here it is a shaft which has displaced, and all what you have to do is reduce the shaft to the proximal humerus. So that balances and that reduces, and all what you have to do is correct the adduction, translation, and internal rotation of the diaphysis to get a reduction in a two-part. So when you're reducing the three-part, so always when you're reducing the two-part, you should not attempt in this position, particularly in an elderly. You have to unlock, otherwise the cancellous bone there will be crushing of the cancellous bone, and when you reduce, there will be a large medial void which is difficult to leave like that. It has to be grafted. So first disimpact and then reduce the shaft by adduction. So in a three-part, where there is a separate tuberosity and the head fragment usually is a large fragment, so you have to reduce by externally rotating the humeral head. That is, you're neutralizing the subscapularis. Then only your head fragment will reduce, and then reattach the greater tuberosity to that fragment and connect that to the shaft. In a four-part, where both the tuberosities are separated, the head is really small. It is an anatomical neck. So you have to reduce the tuberosity beneath the head segment. And how do you check that? The greatest tuberosity should be at least 8 millimeter inferior to the superior most part of the humeral head. So to get a good valgus, your tuberosity has to be below the highest point of the articular surface of the humeral head. Then only you will get a valgus or a normal humeral head reduction. So the articular surface has to be always above the tuberosity. So in a four-part humeral fracture like this, the case which I am describing, you can see here the most important part when you are seeing the 3D CT is first you identify the bicipital groove. The arrow here represents that. On your inner side, on the inner side is the lesser tuberosity, on the outer side is the greater tuberosity. And in here, what you can see in the lateral view, what is anterior to the left is the lesser tuberosity, which is comminuted, which is avulsed. And on the lateral side, on the center, you have a greater tuberosity, which is again split into two, dividing that. And that is how is the configuration of this fracture, which is seen on the X-ray. When you try to reduce that, either the fracture may get displaced or it may reduce. So the workhorse for treating such fractures, which are either you have a fracture dislocation, you have such bad fractures, is a deltopectoral approach, which is you start from the coracoid tip of the coracoid process and go anterolaterally. It is an internervous plane where you have to separate the deltoid and the pectoral. The cephalic vein is an identification, and even if it ruptures, all what you can do is you have to ligate that. So at this stage, there is no need to reduce it. So with the it's an interfacial plane wherein you can dissect that clearly. So very often you tend to, if you're not careful, you may rupture that cephalic vein, but you can ligate that always. And having identified the coracoid process, if you run your finger down, you will be in that intermuscular plane where the chances, if you start from bottom to up, the chances of having ruptured that or iatrogenic rupture of the cephalic vein is very high. So the key here is always start from superior to inferior. and gently abduct the arm, then the deltoid, it falls back laterally, and then you can go directly on the humeral head. So the first, once having separated the two by abduction, the pectoralis major on the inner side and the deltoid on the outer side, you have to dissect to identify the most important structure, that is the long head of the biceps, through which you can identify what is on the inner side will be the subscapularis or the lesser tuberosity, on the outer side would be the greater tuberosity. Now, after having identified that biceps tendon, so this is the biceps tendon, which you can never miss. It's a, yeah, so that is the biceps tendon. You can easily identify that. Okay. So this is the identification. And then the tendency is you take a bone hook or try to pull the greater tuberosity. But what happens is, like if you, in an elderly, if you try to do that, the greater tuberosity will be comminuted. So if you have to use it, the bone hook, it should always be used at the musculotendinous junction. And then you can pull back the entire tuberosity, on which you'll be taking the sutures through the musculotendinous part, not through the bone. It is always at the musculotendinous part, which is the strongest part of the tendon or of the entire tuberosity. Once having done that, then actually you can, a bone hook is always helpful because if you have to go posteriorly, or if you have to take a bite in the posterior half of the greater tuberosity, so that will reduce, or that will give you a better anchorage of the sutures, and then you can take both the tuberosities in the suture anchor like this. So either you can use a fiber wire or a ethibond. Either of them, it does not make any difference. So on the right side, the one with the left arrow is the suture which we have taken through the lesser tuberosity. So that takes control of the retroversion. So the head which is pulled down and the shaft is usually up. So if you give a pull to that suture on the lateral side, the retroversion part is taken care. And the sutures which are on the greater tuberosity, on the supraspinatus and the infraspinatus, if you pull them down, most often the varus will be corrected, provided there is some attachment to the humeral head. So the most secure anchorage in the rotator cuff tendon is just below where it inserts in the bone. Now we come to the reduction of the shaft here. So there are various ways by which we can reduce it. The most important is a small periosteal elevator, wherein you insert through the fracture like this. Okay. So once you insert through the fracture, having taken earlier the tuberosity sutures, and subsequently you have to correct the varus with that. So what you require is just turn the elevator upside down like this and gently elevate it. Okay, right. So then once you elevate it, your head, which is in varus, you will be able to correct it. But you have to be very careful in doing it in an osteoporotic shaft. So that should not be done in those elderly who have too much osteoporosis. Or when you are using this maneuver, the periosteum should rest on a strong cortical bone, not on the cancellous part of the bone. The other tool which is very helpful is a K-wire, wherein Shailesh has suggested one thing, that if you want to maintain the valgus, what you can do is, having corrected with the help of a K-wire the varus, then you can transfix the head to the glenoid. That means you transfix the K-wire in the glenoid so that the head remains in that position. And all what you have to do is reduce the shaft underneath that. So K-wire having trajectory wherein you enter through the superior most part, because that will not come in the way of your plate placement. It will be away from the plate. So that trajectory has to be like that. And then once you give a varus, that varus will be corrected and the head can be brought at a higher level from the tuberosity. So the other maneuver is using a bone hook like this, but again, that wherein, so on one hand, you have a K wire with manipulates which controls the humeral head. The other shaft is then hooked with the bone hook like this, and you try to bring it underneath so that you have a good medial cortical reduction like this. So again, this has to be at the good cortical part of the shaft and not through the cancellous bone. And you can see the head which was comminuted, which is in varus, it has been brought underneath very well. And once you get that, this is not a true AP view. That is why your head is appearing like that. And once you get that, you transfix the head either to the glenoid or from the greater tuberosity, you introduce a wire which will be in the shaft, so that now the head which you have reduced, which is in valgus, is controlled with this second K wire. And then lateral to the bicipital groove, what type of plate you are using, you can place it well, and either you can take those sutures which you have taken earlier through the plate, or afterwards you can do that. So the most important screw is a cortical screw which has to be in the shaft. The importance of that is you have a situation like this. The cortical screw will be helpful in reducing whenever you have a shaft which is on the inner side. It will not be useful when you have a shaft which is already reduced like this. So once you tighten it, so the plate will sit on the shaft and the head. So you have a situation like this where a plate reduction is not very helpful. In fact, it has lateralized the shaft as against the humeral head. So here is a situation where you can see the head is on the medial side, and if you put a plate on the lateral side and use a cortical screw, the shaft will be pulled towards the shaft, towards the plate, and then on the medial side, or step which you are seeing in the second picture is reduced now anatomically. So this is the plate reduction which will be helpful if the shaft is displaced medially. It will not be helpful when your shaft is already lateralized. The most important is knowing what is the height of your plate. So if you have a comminution, if you are shorten the reduction, or you're not sure of the height of the plate, what you can do is you can put a K wire which will be through the calcar screw, this row screw, and then you can check whether it is going and hugging the medial calcar. So this is the longest screw and it should be at the inferior part of the head. So that ensures that you have corrected the varus. So that has to be checked in an external rotation view. Now you can see here, these calcar screws are not in the calcar. They are not supporting the calcar. They are in the center. So there are two reasons. Either your plate is too proud or your reduction is not proper. In both the situation, your calcar screw will be in the center and they will not be in the calcar part of the where they are ideally supposed to be, because this is an anatomical plate. All the screw holes, all the screws which are passing are meant to be in a different part of the humeral head. The proximal most, the center, the second row, and the third row, and the calcar one. Now, another situation is the head is retroverted. That is the humeral head, it falls posteriorly as against the shaft, which is anterior. So that reduction has to be, we only look at the AP view when you are reducing it. Even this is important, otherwise your plate will not be in the center of the head and shaft. So this is the lateral view which you should aim at, so that once you get a reduction, your screws will fan out in all the directions of the humeral head. If your head is in varus, if the head is in retroversion, your screws will be in one quadrant of the humeral head, and that the chances of cutout of this is very high. So I usually take a plate view wherein I just internally rotate the humeral head and rotate the C-arm to get a good end-on view. And the aim is the plate has to be in the center of the head and the plate has to be in the center of the shaft. And other normal AP view or the screw view, what is called, is by doing external rotation, you can see all the trajectory of the screws. Okay, these are how we pass the other screws. And then once you have passed the adequate number of screws, you can do either pass the sutures, the tuberosity sutures, which we have taken earlier through the plate at this stage, which is very difficult. It is better to do it just before placing the plate on the lateral side. So at the end, when you do that and fix the suture, you should get a complete coverage of the tuberosity to the good anchoring of the tuberosity to the plate like this here. So when you pull it, you can see you can lift the entire humeral head along with the plate. Okay, so that is the strength of the suture anchor, pull through sutures through the tuberosities. And once having fixed the tuberosity, you can see you have a good reduction and a good position. Now we are not sure like how many screws are enough in the humeral head. You can see either there are 6 screws, 7 screws, or 8 screws. What has been studied in this paper is 5 screws are all what is required if you want a good fixation of the humeral head to the shaft. And out of this, the calcar screw are the most important. Usually this screw should have a cascade effect. That means the superior screw have to be smallest. They are usually of the average height patient, Indian patients. They usually are of 30, or in female it may be of 25. The second row screw have to be larger. They are usually 35 to 40. And the longest screws are to be the calcar screws, which are again 40 to 45 depending on the height of the patient. So the longest screw should be in the calcar. So smaller screws in the superior, longer screw in the center, and the longest in the calcar. So this is a cascade effect, and 5 screws are enough in the humeral head. So out of that, which one should be left? Tingard, in his paper in 2006, had studied the BMD of the humeral head. And according to him, the most porotic part of the humeral head is the anterior half. So if you have to leave some screws, leave the anterior one of the plate. The posterior one, which has a good bone, which has a good bone mineral density, should always be utilized, and only 5 screws again are good enough. Rest of them you can leave it. There's no need to put screws in each and every hole in a proximal humeral head. Remember, your reduction has to be anatomical, then only the screws will fan out in all the quadrants of the humeral head. So that was about the plating. What are the important reduction techniques? What would be helpful to you when you are doing the fixation with the Philos plate? So you have a situation where there is a poor medial column support. And in this situation, either a second plate or a fibular graft is very useful, which has been used here, an intramedullary fibula and a long anterolateral plate. And you can see the head, the reduction is maintained. The head is above the tuberosity, the number of screws in the humeral head, the shaft which has been completely incorporated at the end of 1 year, and he has a normal range of movement. So to conclude, again, the reduction is the key, and do not leave the head in a varus. Restore the calcar part so that you get the automatically, if you restore the calcar, you will get a normal valgus, and the chances that you will end up in a varus are very less. Remember, all the results, all the problems with the plate are because you have not reduced it anatomically on day one. So that was all about the reduction technique and the approach, how you can use it for fixing such 3-part or 4-part humeral head fractures. Thank you. Any questions?
Cephalic vein, you do take it to medial side or lateral side?
Come again, Rakesh.
Sir, when you are doing deltopectoral approach, the cephalic vein is there. You take it to the medial side or to the lateral
side? Always lateral side.
Always lateral. And second thing, when as you said, the first screw should be cortical if it's medial. If it's lateral, then what to do?
So you have to reduce it, and you can use you don't have to use a cortical screw. You can use directly a locking screw.
Your first screw is locking screw, disc in the shaft.
When your shaft is lateral, okay?
Yes, sir. Yes.
Or is in the center, head
Yes.
is reduced. So you don't want the shaft to go laterally.
Yes,
right?
sir.
In that situation, your reduction, you have already reduced it. All
Yes.
you have to position the plate. So you don't need a cortical screw in that situation. You have a situation like this, where the shaft is on medially. You have to push to get the reduction. In that situation, you are supposed to use a cortical screw.
Well, in that case, first screw you put always to the shaft, either cortical or locking.
Cortical.
See, locking if it's already lateral.
See, then the other important things are, you used a K-wire to position. You have a situation, what you are talking, where you have achieved a good reduction, right? The shaft is underneath the head. There is a good reduction. So what you need is put the plate on the shaft and the head, position it by putting 2 K-wires proximally and distally, take EP and lateral view so that you ensure your plate is not proud or it is too distal, and then pass a K-wire, which should ideally be in the K-wire should be through the calcar screw. So that ensures again that your plate is not proud. If the K-wire is going in the center, that means either your head has fallen back in varus or your plate is little superior. Am I clear now?
Yes, I am. Yes, absolutely clear.
Any other questions? So it's 10 o'clock. If there are no questions, we can close today's session. And we again thank Dr. Shailesh for giving and sparing so much time in the evening. Thank you, Shailesh, once again. And we part today. So good night. And
Good night, sir. Thank you, sir. Thank you.
Thank you, sir. Sanjeev, sir.
Thank you.